Dr. Donald Barone is a professor and chief of the Division of Neurology at Rowan University School of Osteopathic Medicine. He is a graduate of Rutgers College and Philadelphia College of Osteopathic Medicine. He has served on the Healthcare Advisory Committee for the National MS Society Greater Delaware Valley Chapter for more than 30 years and is current co-chair, frequently lecturing on behalf of the Society. He has also served on the Healthcare Advisory Committee of the MS Association of America for more than 15 years, also lecturing on their behalf. He was appointed to the New Jersey Multiple Sclerosis Task Force in 2013-14 by State Senate President Stephen Sweeney and Governor Chris Christie. He was involved in laboratory research early in his career and clinical research in subsequent years. His research interests include neuroimmunology, clinical trial therapeutics development, epidemiology, and gait impairment in MS patients. He has publications in many peer-reviewed journals and has presented research findings at many peer-reviewed venues. He has a busy clinical MS practice at Rowan Medicine. Please give a warm introduction to Mr. Barone, or Dr. Barone, sorry.
Hi, thanks. Thanks for your kind introduction, and thanks to the association for asking me to speak here today. It's a pleasure to see everyone. The objectives that I wrote for this presentation for CME purposes included understanding basic epidemiology and immune pathogenesis of MS. We'll have a couple of slides on that just to give you an idea of how this disease process happens. I can tell you that we still do not know the exact quote-unquote cause of MS today, but we know how the damage occurs. We know the immunopathological mechanisms and the molecular biology of how the damage occurs. So with that knowledge, therapeutics have been developed to interfere with the destruction and damage of tissue, and that's how we've been able to help patients with multiple FDA-approved therapies. Second thing is, I'm going to make you aware, I hope, of the current approved MS therapies for MS. I'll show you a timeline and give you some perspective on how these developed over time. I witnessed it all. I've been doing this long enough to have spent 18 years of my career before there were any therapies. And the third thing we'll talk about that you hope you'll find interesting and you may not be as familiar with is the current concepts about the roles of vitamin D and the gut microbiome in multiple sclerosis. Vitamin D and the gut microbiome are being looked at in multiple autoimmune illnesses and in other health conditions. So we'll move along and let me get the slides going. Okay, so the general outline will be epidemiology, clinical overview. Immune pathogenesis, we'll go over the approved therapies. I'll group them for you, then I'll show you a slide with a timeline. We'll talk about vitamin D and the gut microbiome. And in the course of looking at the epidemiology and the clinical overview, I'll show you some MRIs to give you some concepts about how we use MRI, which has become very important to us in the diagnosis of MS and following up patients with MS. The diagnostic criteria for MS have evolved over the last 50 years. One of my early mentors, George Schumacher, developed the Schumacher criteria in the 60s, and it really involved the clinical perception and observation and documentation that a patient has suffered 2 or more lesions in the central nervous system, demyelinating in nature, disseminated in time and space. So that was key. Later on in the 1980s, Dr. Charles Poser, who was my chief, developed the Poser criteria, adding spinal fluid and evoked potential studies. The current era began in 2000 when it comes to MS diagnosis, and Ian McDonald conveyed a committee in 2000, and there have been multiple updates to the diagnostic criteria, still incorporating what Dr. Schumacher, Dr. Poser started by adding MRI. So MRIs become very important. I'll show you some of those scans and some of the features of the MRIs that are very useful to us. So talking about epidemiology, so we know there are 400,000 patients approximately in the U.S. The problem with that number is that the data goes back to a data collection done in 1975, and an exact number is hard to come by. There is current research being done to try and really pin this down. We think there are more patients. We would like to be able to verify that because those of us who are involved in advocacy for MS patients would have more clout if we could verify that there are in fact more cases. It's clearly more prevalent in temperate climates. We know that to be a fact. There's little or no MS at the equator, and as you get into the northern and far southern latitudes, there's more MS. Part of this may be environmental, part of this could be sunlight. We'll talk about vitamin D, and that comes up in the discussion, and part of it could be genetics, because they all play a role for sure. There was an interesting epidemiological study that was done by Milton Alter, who's a colleague and was a former chairman of neurology at Temple. And he's retired now and did this probably back in the 70s. And the state of Israel became a living laboratory after its inception in 1948, with all the emigration to a subtropical climate from Northern Europe. And the observation that was made and published was that if an individual moved to Israel from Northern Europe before they were 15 years of age, they seemed to acquire the relatively lower incidence of MS that was prevalent in the subtropical climate, as opposed to moving there after 15 years of age, when they seem to bring with them the higher risk of MS. Little observations like that have been made over the years. We haven't totally sorted out the puzzle of why this may be true, but the temperate zones clearly have a higher risk, no doubt about it, whether it's genetic, environmental, combination of both. And today, vitamin D levels, of course, are lower in temperate zones and higher at the equator. All these things come into play. So this is a women's symposium, so MS is more prevalent in women for sure. I have done studies on my clinic cohort looking at basic epidemiology and the comorbidities with autoimmune illnesses, and we did a retrospective study. I have medical students work with me all the time, so we have willing researchers, and we looked through 400 charts back in the day when they were still paper, and we know that from that data set of 400, 77.3% of my clinic cohort are women. Modern cohorts are typically in the 3 to 4 to 1 category, women more than men, when they're reported from individual clinics. When I was training, it was said to be 2 to 1. There is an exception to that, and the one exception is when we get to a type of multiple sclerosis called primary progressive, which is different. It doesn't start with relapsing disease. It starts later in the 40s and 50s. It's typically spinal, and there's not as much in the way of brain problems or optic nerve problems. And these patients in some cohorts are about 50-50 men to women, and in some cohorts there's even a slight male predominance, but they make up only 15% of MS patients at onset. 85% are the relapsing remitting patients, and they are the dominantly female part of this subset. The age of onset is typically 18 to 55. 20 to 40 is what's commonly quoted. 18 to 55 is typically the age range used to collect patients who are willing subjects for clinical trials. There have been no clinical trials in patients under 18, so we have no objective clinical data in a clinical trial setting on pediatric MS. However, there's a lot known about pediatric MS based on data collection done by Dr. Brenda Banwell and a group of our Canadian colleagues who have a pediatric MS cohort, which is a funded program that's ongoing, and she's the principal investigator. She's moved from the University of Toronto to CHOP, and she's in our area now. She's the head of pediatric neurology at CHOP, so we know a lot about it. There are certainly practice guidelines, but there's no clinical trial data on the pediatric age group. The youngest patient in my personal practice was 13 years of age. Most children younger than that who might have MS would be going through the pathway of a pediatrician, pediatric neurologist, and then children's hospital or a like institution. But I have a very large practice, and this young lady's parents, so one was a patient of mine with multiple sclerosis, so I got to see her first. I still see her today. She presented with numbness, tingling of the legs, thought it might be a neuropathy, did conduction studies, they were normal, got an MRI, there were some suspicious lesions. I did a spinal tap, and she clearly had findings of oligoclonal band supporting the diagnosis. 2 months later, she got optic neuritis. So it was clearly an obvious case, and I've managed her. She's about 34 now, has done reasonably well, but has had more disease activity. Genetic predisposition. So there's clearly a genetic predisposition, and there's a couple of lines of data that make that incontrovertible. One is that if a first-degree relative has MS, so your first-degree relatives are your parents and siblings. So if a parent or sibling has MS, the odds of you getting MS, the prevalence in the first-degree relatives is about 2 to 4%, depending on the data set that you look at. Now, it's hard to clearly give an exact prevalence in the general population. However, if we're going to have a reasonable guesstimate that there are 400,000 MS patients and that our population is approaching 400 million, and you do the math, it's about 0.1%. So there's clearly a significant difference. We know more about it than that. Our Canadian colleagues have MS clinics which are mostly government funded. They have a single payer system there plus private medicine. And so the clinics are easily able to cooperate with one another. And they did a study looking at twins in the MS clinics. And they looked at identical and non-identical twins. Of course, non-identical twins are the same as other siblings. They have their own unique DNA, though they're obviously closely related. And identical twins, by definition, have the same DNA. So when they looked at the coincidence of multiple sclerosis, the non-identical twins were in the 2 to 4% range. Not surprising. That's what is generally seen with first-degree relatives. The identical twins had an overall coincidence of 30%. And the women were about 33%, the men about 25%, so the MS is more prevalent in the women, and there would be more women to count in that study for sure, because that's the demographic that we see. It's interesting, and a rhetorical question that I often ask when I present this data, and I speak about MS fairly commonly, is, so what's not identical about identical twins? And the best answer that I can think of is certainly their immune systems. They're certainly in a similar environment, but they might not have exactly the same exposures. And not only is the type of exposure important, but epidemiological and immunological data suggest that the sequencing of exposures and also the age of exposure might be very important in how one develops the risk for multiple sclerosis. I think that there are two places in us where we remember, and one is in our central nervous system in our brains, and the other is in our immune system. I remember having chicken pox when I was a youngster because that was pre-vaccination, and I would bet that if I were to get a VZV titer, I would have a signature of that infection. So something in there is remembering that I had chicken pox a long, long time ago. So the immune system remembers, as does the brain, and it is quite unique. I think our immune systems, if looked at properly, are an absolute unique fingerprint for each and every one of us. So we're going to move on. So clinical overview. So how does MS present? Well, there can be many atypical presentations. We'll get to that in a minute. But the three most common ones that we see, of course, are optic neuritis, where patients have an inflammation of the optic nerve. They may have pain behind the eye when they move the eye. They certainly have blurred vision. They may have a blind spot in their vision. If it's severe, they could be near blind in the eye for sure. But optic neuritis is a common presentation. One of the more subtle clinical findings in patients with optic neuropathy of any type is that if you were to test them for color vision, and you don't need to do that necessarily with Ishihara color plates or American optical color plates that you've all seen. I use a red cloth in the office for a quick screen, and if the other eye is healthy and you cover one eye then the other with a bright red cloth or a picture or a piece of paper, the red color is not perceived as vividly on the side of the optic neuropathy. That's thought to be perhaps the subtlest clinical marker that there can be an optic nerve problem there. Just a little tip for you. Sensory myelitis is one of the common ones. The first three are the three common ones, and the next is brainstem cerebellar. But sensory myelitis typically begins with numbness and tingling in the feet and toes, kind of moves up the legs, and may settle in around the waist or the chest, and the patient feels numb and tingly from there down. They have a little trouble walking. They have a little difficulty with urination. They may have some retention or some urgency because of the spinal cord involvement. There's clearly a spinal cord lesion. But the interesting thing about MS myelitis is that it is sensory more than motor. Spinal cord inflammation, it's sensory more than motor, as opposed to another disorder we call acute transverse myelitis, which is a demyelinating disease but a different type, and that's motor more than sensory. And there's another variant of MS called NMO, or neuromyelitis optica, and we have an antibody for this test now, and it's important to recognize for me because the treatment is different. But these patients have more motor involvement very often. So if we see someone with a new onset of an immune-mediated myelitis, and it's more motor than sensory, where we're thinking about other things besides MS, there is a differential diagnosis. The brainstem cerebellar syndrome is the third most common one, and these are patients who present with imbalance and double vision. The eyes are disturbed in two ways with MS. One can be directly by optic nerve involvement. The second can be by brainstem involvement, whereby the oculomotor control is disturbed, and if the eyes do not move in perfect coordinated fashion, there will be double vision. So you get disturbance of the brainstem oculomotor pathways, and this will clearly be a major presenting complaint for some patients. Beyond that, you can get hemiparetic syndrome. It can look a bit like a stroke, but it won't have a sudden onset. But it can be confused, and I've seen patients admitted to hospitals with the diagnosis of stroke, and it turns out to be MS. But the onset is, of course, not as acute. That happens maybe 5 to 8% of the time. It's not the most common presentation. There are a number of atypical presentations as well. I reported a case at the Consortium of MS meetings several years ago of a woman who presented with an acute cognitive syndrome. It is unusual, but there have been others reported as well. This was a woman who went to work, and she was a supervisor at a Kohl's store. And she came in the morning, and she was back at the customer service desk, and someone came in to return something. And she was at the computerized cash register, and after working there for 15 years and doing this all the time and being a supervisor, she was unable to process the return. She didn't know how to do it. She didn't know what came first. This is a clinical syndrome which I recognized as a neurologist called ideational apraxia. And it is localized. There's a focal lesion, usually in the dominant parieto-temporal area, which will cause this to occur. And I was seeing her 3 weeks later, and she had gotten better, and I think she was 50-some years old, and I thought she probably had a small stroke, and what else is it going to be? And we do an MRI, and she has a large demyelinating lesion where I thought the stroke would have been, and she has other lesions of MS. So these things do happen, but they are rare. The next thing on our clinical overview is radiologically isolated syndrome, and I'll show you a few MRIs on the next slides to get you up to speed with this. So with the MRI, all right, there's no one test today that is absolutely yes or no for MS. We still don't have it. Been looking for it for a long time. We have a new research initiative we're going to start at Rowan, which may get us closer to that, but it's barely getting off the ground. We haven't gotten all the funding yet. But right now we don't have such a test. So the MRI, though, has gained importance, but the MRI by itself can't absolutely be a yes or no MS diagnosis. But sometimes we see an MRI that has certain characteristics that would make me bet my house that it's MS. However, we can't make the diagnosis at that point in time without clinical signs compatible with MS. And this phenomenon has been seen by others around the world, and a couple of groups have been studying it. We call this radiologically isolated syndrome because it looks like MS, but no clinical signs. We can't call it that, but we think that these patients are at high risk. And a colleague of mine, Dr. Darren Okuda, who started looking into this when he was a MS fellow at the University of California at San Francisco, and he's now at the University of Texas in Dallas, has studied it, written about it, and he's collaborated with a group in France. And we've learned a few things. One is that if there are spinal cord lesions associated with brain lesions that look like MS, and I'll show you some in a slide or two, those patients, when followed, and these are not large data sets, we're talking about several dozen patients, not thousands of patients, but if there's a spinal cord lesion that looks like it's demyelinating, within 2 years, 82% had clinical MS. So this is an important clue. We know for sure that there's MS MRI activity before there are clinical signs. We know that that's a fact. We know that to be true. There's MS activity and that it's subclinical, doesn't cross a certain threshold so the patient's symptomatic. And sometimes we pick this up. Sometimes it's someone who's in a car crash. They bump their head, you get an MRI. Sometimes someone has a headache, you get an MRI, and then I get a consult. What are all these white spots? Now, not every white spot you see is MS. A lot of people have white spots that are nonspecific and have nothing to do with MS. It's challenging to make that call, and that's part of what I do for a living. But there are some characteristic scans that I think are high risk, and I follow them very carefully. If there's more disease activity, we can have a discussion with the patient about starting something. If there's a cervical lesion associated with the brain lesions, they're watched very, very closely. There's really no other guideline or consensus in management right now. So the types we talked about, we already mentioned the relapsing remitting type of MS. 85% present that way, and we said about 15% present with primary progressive forms of MS. The secondary progressive patients are those who have had relapsing remitting MS, and over time, even in the absence of relapses, and time often means 10 to 15 or more years, the relapse rates go down, whether you're treated or not, and then slow progression will continue in the untreated population. We would like to think we've changed that paradigm with therapy, and I'll show you some more information about that. Let's move on. All right, so some of the MRI lesions I promised you. So if you look, there's different ones here. There's T2 flare, there's the T2 in the top left-hand corner, and that typical white matter lesion just outside the ventricle in A would be very suspicious for a dominating lesion. It is ovoid. It is more than 3 millimeters. On a T2, it's a hydrogen-dense, a hydrogen-weighted image, so water is going to light up. H2O, there's a lot of hydrogen there. In the T2 flare, you get the same ability to see water-rich tissue, but the flare, fluid attenuation inversion recovery, makes the near pure water dark, so you can see the white brain lesions better. So the ventricles there appear dark, and the sulci out by the cortex is, of course, dark, and that helps us. The T2 flares are very, very useful. When you do T1, you can see some dark spots there. So all MS lesions start as a T1 black hole, a T1 black spot. That's edema at first. Then if you look at the T1 GAD, they light up for about 2 to 12 weeks. No more than that. They light up for about 2 to 12 weeks. Then they may either become iso-intense with the brain again, or they may be a signature T2 lesion that remains. If a T1 black hole stays longer than 6 months, and this is all data-based, not my opinion, Comey and others in Milan and Italy did this research. If it stays more than 6 months, it's an area of tissue destruction. It's like they had a little infarct there. It's like a lacunar infarct. We have one more. So the McDonald criteria are displayed here. So I hope it's showing up well enough for you there. I think it's pretty good. So gadolinium enhancement is seen in the top left-hand corner, and sometimes it is ring enhancement, as you see there. It may not be the whole lesion. T2 hyperintensities are the T2 or the flare lesions that you see in the middle, and then when you move to the right, lesions in the posterior fossa in the brainstem or cerebellum are typical. Lesions right next to the cortex, the juxtacortical ones, are typical. Lesions right around the ventricle are typical, and then spinal cord lesions can be seen. They're generally best seen on T2 or flare images, where the spinal fluid looks on the, whitish, and then the cord is grayish. Within the cord, you can see the white lesions. But these are the typical areas and sizes and shapes of lesions that would make someone like me, seeing a patient who doesn't have an MS diagnosis, very suspicious because size, shape, location. Okay, immune pathogenesis. So a few basics for you. All right, and this has to do with most any immune reaction. So antigen presentation and lymphocyte activation. So what happens is something enters us. Is it a bacteria? Is it a virus? Something happens in the periphery, not in the nervous system or any particular organ. There's antigen-presenting cells, which can be any immune cell, but they're often dendritic cells. And they recognize and attach themselves to the antigen, and then they hook up with a lymphocyte. And in doing so, when they hook up with a lymphocyte, there's activation of lymphocytes. Adhesion molecules increase. These lymphocytes clonally expand. There becomes a population of lymphocytes that react to this antigen, whether it's virus, bacteria. Then what can happen in MS, if the antigen is something that will cause it to home in on the central nervous system, is a few things happen. And adhesion molecules become upregulated. So when cells are in circulation, if they want to get into the tissue, whether it's the gut or whether it's the lung or whether it's the brain, they have to be slowed down from circulating, and they start to stick to the endothelial wall, the vessel wall, and then they adhere, and then they crawl through the wall and into the tissue. So they get through the blood-brain barrier. So MMP, or matrix metalloproteinase 9, aids in the diapedesis. It melts away some of the collagen tissue in between the cells, and the tight junctions are changed. And then there's a release of inflammatory cytokines, which cause damage, and antibody-damaging myelin neurons. So it starts in the periphery. There's some antigen presentation. Lymphocytes get excited. They start to activate. They start to clonally expand. They start to hone in on the target tissue. They stick to the vessel wall. They crawl through. Once they get in there, cytokines cause problems, and antibodies, sometimes working with complement, cause damage to myelins and neurons. Be aware that we are all taught that MS is a demyelinating disease. I'm here to tell you that's not entirely true. Axons are damaged very early in MS. There's clear neuropathological data to verify that. And neurons are damaged too. There's neuronal loss. There's brain atrophy that occurs over time in MS patients. Brain atrophy is an indicator of disability progressing. We don't use that as a marker because by the time you can see it easily clinically, it's too late. There are ways to look for subtle loss of tissue in research. So if you look at this over on the left-hand side, there's a resting T cell, not doing much, just hanging out. An antigen-presenting cell comes along, and this antigen-presenting cell attaches an antigen to it. That T cell becomes activated. Its DNA gets activated. It starts to reproduce itself, and you get a clone of activated T cells, Th1 cells. You can see once that happens, then that MMP I told you about, matrix metalloproteinase, helps it crawl through that blood-brain barrier, which are the endothelial cells. The cells get inside. They may be reactivated again. They produce tumor necrosis factor alpha, interferon gamma, IL-2, interleukin-2. These are all inflammatory destructive cytokines. And some of the cells that get in are B cells, and they can produce antibody and cause damage that way as well. All right, so we're going to go over currently approved therapies. That gives you some idea. So all of the therapies that help interfere with that process, all of the therapies that help. So there are interferons, first of all. Beta interferon 1B, beta interferon 1A, glutaminyl acetate. These are the injectable therapies. These were the first ones approved. Beta interferon 1B, 1993. It was a big deal. Most of us in the Philadelphia area were interviewed on the 5 o'clock news about this new discovery, and it was the beginning of the era of treatment for MS. The brand names are on the right. Xtavia is a generic type of beta seron. The 1As are Avonex, Rebif, Plegridy, and glutaminyl acetate is Copaxone, and I'll show you a timeline as to when they all came out. Glatopa is a new generic form of Copaxone. So the oral therapies, there are 3 oral therapies. Fingolimod was the first, introduced in 2010, Gilenya. It's once-a-day tablet. Teriflunomide Aubagio, introduced in early 2012. It's a one-a-day tablet. Dimethyl fumarate, or Tecfidera, is the one you see on TV all the time. That is a twice-a-day tablet. They all have FDA approvals for relapsing forms of MS. Every medication you will see on these lists are approved for relapsing forms of multiple sclerosis. There are no FDA-approved therapies as of today for progressive forms of MS. That may change. At a lecture next year, we probably will have something to tell you about a drug for progressive MS, but not today. All right, so these are approved IV therapies. Natalizumab, or Tysabri, has been around since 2006. First came out in 2004. There was a problem with complications in PML brain infections. It was taken off the market, studied extensively, brought back to the market in 2006. Alemtuzumab, Lemtrada, just came out in 2015. It's a very potent medication that has amazing efficacy, but it also has a risk profile that requires careful monitoring, and lab work must be done monthly for 4 years after you finish it for various reasons. But it is extremely effective, and there are times when it is appropriate, absolutely. Mitoxantrone, or Novantrone, is a chemotherapeutic agent, which I don't use anymore. But it was approved, it's still approved. In 2001, it was approved. It was shown to help progressing forms of MS. Because 77.3% of my patients are women, and mitoxantrone is an anthracene dione, It occurred to me many, many years ago that I don't think I'm going to embrace this medication extensively because anthracene-dione is the same class of drug as adriamycin, which is an important chemotherapeutic agent treating breast cancer. And so a full course of mitoxantrone would take that off the table if one of my patients was to contract breast cancer, and I take care of a lot of women. So I don't use it anymore, and I used it little in the past. But there was a time when if someone had bad progressing MS, there was no alternative. But we have many alternatives now. So I hope you can see that fairly well. It's a timeline that just goes over what we talked about. So 1993 with beta-seron and the other drugs coming along, it just gives you a sense of where we were and where we are and how many therapies we actually have now. A number of them are in the same category like the interferons. So the vitamin D story is a very interesting one. When I grew up, vitamin D was for strong bones and healthy teeth. And we've always known about vitamin D's importance in managing bone health and its importance in bone health. But we clearly know, without a doubt, that it is a hormone which interacts prominently with the immune system. There is no question about this. There's large literature on it. The literature search will bring you many, many references for this. We know a few other things. We know that low vitamin D levels have been associated with increased MS relapse rates and greater disability progression. There are a number of data sets to show that. And Dr. Banwell, whom I mentioned previously, and the Canadian group that's looked at MS and pediatric MS has shown and proven that in children, low levels of vitamin D are associated with increased risk of getting MS. And that's incontrovertible. There's little or no doubt about that. So it brings up an interesting issue when I see parents who have MS and they have children. The question comes up, what do we do for the children? Should we be giving them vitamin D? And I think the answer is yes. I think the data is there to do that. When it comes to dosing the children, I generally ask that the pediatricians do that and follow levels. We have good guidelines as to what levels are going to be helpful for patients with MS in reducing their relapse rates and lowering disability progression. So we look for adults to have levels of vitamin DOH or dihydroxy. That's the one we measure. And be aware, when I give you these numbers, these are the North American and American Canadian numbers. It's measured differently in Europe. We measure nanograms per milliliter in the US. In Europe, they measure nanomoles, so the numbers are 2.5 times higher in the European literature. So 40 to 60 nanograms per milliliter is the target that we have. If you look at your average labs for vitamin D, they'll tell you that over 20 is probably okay and over 30 is fine. It's not what the MS data shows us. And I don't think anyone knows exactly what the right level is supposed to be. I do know that it's pretty hard to become toxic with vitamin D. And I'll have patients go up to 100, and I found no literature that would be a problem. 200 or 300 I don't target. I think that's unknown territory, but it's certainly unnecessary. So when I dose adults, I generally use vitamin D3, and I use 5,000 units a day, give or take. It can be a little less in some patients. I follow levels in my practice. I put a lot of time and energy into following vitamin D levels in MS patients. I think it's that important. I personally take 5,000 a day because I think it's a good idea. But that's something for you to consider now. This is an MS talk, but be aware, if you talk to the docs who take care of Crohn's disease and lupus and other autoimmune illnesses, there's a great interest across the board in vitamin D. And I do pay a lot of attention to it based on the data that I have in multiple sclerosis. It is something that, when you look at the risk-benefit ratio, it's pretty favorable. I mean, I wouldn't tell you that the whole story about vitamin D and MS or any other illness is fully written yet, but the risk-benefit ratio is pretty much, it's a home run. There's not much to lose, and there's something to potentially gain. So, the gut microbiome. I would hope you might find this interesting. I have not done any primary research in the area, but I've done a lot of literature search in the area. One of my good friends is one of the leading investigators in this arena, if you're interested, there's a video that I could refer you to, and you could hear him speak about it. But what we know is that in us, there are about 100 trillion microorganisms. 80% of them live in our gut, and there's probably about 1,000 different bacterial species that we harbor. Most of the time, this relationship is a mutually beneficial and symbiotic one. Of course, we all know as physicians it can get out of balance, and some bad actors can get involved, and then people can get very sick. The gut-associated lymphoid tissue, which includes the Peyer's patches we all learned about in med school, and then the mesenteric lymph nodes, represent about 80% of our immune system. So 80% of our immune system is, in fact, intimately associated with our GI tract. It's a fact. There's no doubt about it. The gut microbiome is very dynamic, and there's a clear interaction with our immune system and our nervous system and brain. Our brain and our gut have been talking to one another forever, and we've known that because when you eat certain foods or you eat too much, all of a sudden you have a sensation of satiety. And that's not really coming from your stomach. It's your brain telling you, enough is enough. And there's clearly signaling that goes back and forth between the brain and the gut. The messaging systems include small molecules in the bloodstream. It includes the vagus nerve and the afferents from the gut talking to the brain, and vice versa. So there's a lot that goes on, and there's without question, it's a dynamic conversation that goes on all of the time. Also, the power of the interaction between the human and the microbiome is reflected by this. Humans have about 25,000 genes. The 100 trillion microorganisms that live in us have collectively genes that have been estimated anywhere from about 2 million to 20 million. They outnumber us in terms of the genes that they have. I would like to think ours are a little more sophisticated, but nevertheless they're there. And there's a conversation going on all the time between the gut, the microbiome there, the genes there, our genes, the brain, and it's a very interesting one. And there have been a few basic science observations that tell us that the gut's very, very important in MS. Most of these have to do with animal models. So there's an animal model of MS in a mouse, and it's called EAE, or experimental allergic encephalomyelitis. It's a pretty simple, something about the mouse genome, okay? The mouse genome and the human genome are so similar, it's pretty scary. A couple of more purines or pyrimidines here or there, we could be crawling around on the floor. It's not that different. But the mouse immune system is very much like ours, which makes it a great model. So if you take myelin basic protein, which is derived from myelin, and you inject it into an appropriate species of mouse, appropriate species means they have the right genes that are going to make them get the disease, and you add adjuvant, which we all learned about Freud's adjuvant or something similar, you create an immune response, and the animals get sick. They get a demyelinating disease of their nervous system, and that has been the classic animal model to study MS for years. It is not a perfect model. It is not generally a relapsing model. It's a single event model, but the immune interactions, the immune effects mimic human MS very much so. So there's a couple of things. There are some newborn mice from mothers who are reared in sterile conditions are born with sterile guts. And in the absence of a microbiome in the gut of these newborn mice, you cannot give them EAE. If you give them adjuvant and you give them myelin basic protein, it can't happen. If you then allow their guts to become colonized, and experiments have been done with fecal transplants from MS patients and from normal subjects. And if you give them a fecal transplant from an MS patient, they get a worse form of the experimental MS than they do from a normal patient. They can get it with a normal patient, but it's distinctly different. So that there's a basic science line of evidence that this is very, very important. Now, it could lead to therapies as time goes by. So the The doctor is Dr. Lloyd Casper from Dartmouth, my colleague, and his lab has isolated a protein from Bacteroides fragilis. It's a common inhabitant of the gut. And the protein that he's isolated in the experimental model can attenuate the disease or they won't get it. So it's clear that, that this is a target-rich environment, a target-rich system, not only for MS, but for all autoimmune illnesses. And there's also evidence that the gut biome and its actions impact atherosclerosis and a number of other conditions. So I hope perhaps maybe you were familiar, but maybe I've introduced you to an interesting topic. You need to read about it. It raises the issue of how about probiotics? Well, they have been looked at, and what kind might be beneficial. It's not going to be easy to come up with a simple solution with an everyday probiotic. There are so many organisms in there that when someone has a variation that makes them susceptible to disease, it might only be a small percentage of the massive number of organisms that exist. So finding strategies to make a difference there is important. In some animal models, if you give someone, and we know what happens if you get antibiotics and too much of them, right? Your GI tract changes, you know it because you've got change in your stool. If you're unfortunate enough to get a C. diff overrun, you're sick for a long time, and you can clearly change your gut microbiome that way. But you don't wipe out all of the organisms. They're still in there. You've just got an imbalance. So just taking a particular antibiotic, is that going to change it enough? I don't know. But there's potential. There's potential here for therapy. One thing I've had an interest in, and I've not been able to gather enough data yet, is that I have a sizable number of my MS patients have undergone gastric surgeries for weight loss. And I would venture to say, I'm not sure about with the sleeve, but with the bypasses, I would venture to say that some alteration in the gut biome has happened. I've not made any observations yet that would make me want to move into an area of investigation, but I think they're an interesting group of patients, and it'd be interesting to see if in fact there are any changes one way or the other. So far I have not seen anything, but clearly all of these interventions will change our gut biome, and the implications are very significant. I think, as I look back over my goals and objectives, I think we've covered them, I hope, and maybe I've intrigued you with a couple of things anyway along the way and given you some idea what MS is about. It is not your granddad's MS anymore. It is not just a demyelinating disease. It is not, axonal damage happens early. Right? There's a famous published microscopic image that came out of the Cleveland Clinic. Bruce Trapp is the neuropathologist who did it, and it clearly shows in a very early MS lesion that happened to be biopsied because they weren't sure it was MS, that there's axonal damage all over the place in a very early lesion. We're not talking about a patient who's had MS for 20 years. So this happens very early on. It's important to understand. We feel, all of the associations feel, that if someone has symptoms of MS, they need to be assessed quickly. You need to make a decision about whether it's MS or it's not as soon as you can, and sometimes it takes a little time. Sometimes even for an expert, it takes a few moments. It's not necessarily a slam dunk every single time, but early treatment is valuable. Early treatment seems to help the long-term outcome. We believe that there's a window of opportunity in early MS to treat patients. Once there is a cascade of events that start secondary progression and continuous loss of nerve cells, the drugs we have today are not proven to be effective thus far. So if there's suspicion of MS, the patients need to be evaluated, you need to make a decision, and all the clinical trials show that early treatment leads to better outcomes. So that's an important message, I think, for everyone to understand. Early in my career, when we didn't have treatments, there was no rush to diagnose MS. Why would we want to label a patient with MS when we couldn't be more sure? Not like today. I mean, we might make them uninsurable, we might affect their work status. So there was no rush to diagnose MS early in my career. But that's changed. The ability to intervene and make a difference does exist, so there is a rush to diagnose MS now, and early intervention appears to be the way to go. All right, so with that, I'll conclude and happy to answer any questions. Yeah. So the question was, with such an array of medications, how do I decide what to use? And that's a great question. And the answer is that we have no biomarkers yet to make the decision, and we really look at the patient's comorbidities, and we look at what the patient is willing to do in terms of injections or non-injections, and every clinician and every patient has a unique risk tolerance. Every one of us in this room, we have our own unique risk tolerance, and that can play a role in the choice of medication. So the older injectable medications have been around for a long time, 20 years or so, some a little longer, some just slightly less. And so there's a long safety record there. And so some patients will say, well, I'm not keen about an injection, but how long? They've been around a long time, I'm more comfortable with that. And quite frankly, if you look at head-to-head, the only way to know which drug's better than another, right? You can get opinion, but the only way you factually know if one drug's superior to another is in a head-to-head clinical trial, okay? If you don't do a head-to-head clinical trial and you have one clinical trial that was done with this group of patients in one era and one that was done over here at another time, you cannot compare them directly. The outcomes from clinical trials are largely dependent on the entry criteria and on the individuals who become part of those populations. So you cannot compare between trials. So we only have a few data sets. So that doesn't help us too much. So it is judgment. There'll come a day when biomarkers, either genetic or immunologic, may tell us which treatments are best. For now, it's a judgment on our part. I still tend to use a lot of the injectables. I have someone on every medicine you saw up there. I have someone on every one of them except the mitoxantrone, which I haven't used in many, many years. But I have someone on every one of them. And it depends on their circumstances, and often it's comorbidity, and often what the patient's willing to do, what the patient's risk tolerance is. And I would tell you there are some practitioners who might not use some of the medicines that I showed you just because their risk tolerance doesn't make them comfortable doing it. I see some patients for other neurologists who don't want to use some of the IV therapies that I use, and I use them. So that's really how it is done. It's a shared decision. If it's not shared, I'm not someone who says, well, Mr. Jones or Mrs. Jones, we have these 14 patients, pick one, and then we'll go from there. I guide them. I'll narrow it down to one or two or three. But I need to have my patient buy in to it. And the main reason is that we know from prescription data that compliance with MS therapies is only about 50%, total complete compliance. So we are losing opportunity to help patients because of that. So if it were to be a dogmatic recommendation on my part, I think that compliance rate would be worse. And I try and make it a shared decision, but I definitely guide. I don't just say, here you go, it's your choice. I guide them. And I sense what their comorbidities are. I might have a sense of what their risk factors are. I ask them. Someone might say, hey, I won't do a shot. Well, okay, that narrows the field. I'm not going to insist that someone do an injection when they told me they're not going to do an injection, because then non-compliance is going to make my job harder, and I'm going to lose an opportunity to help. Okay?
Don, thank you. Thank you for your discussion. I'm just wondering, under gut microbiomes, has there been any studies or implications that antibiotics have been associated with this condition, and taking antibiotics, has it worsened any cases of MS that you know of?
Yeah, so a great question. So the answer is we don't have any data on that, and I'm not aware of any that shows that antibiotics worsen the condition. We just don't have any information on that. There are a couple of other, but let me use your question to expound a little bit. One is that there are medications on the market called TNF-alpha blockers, which are used to treat rheumatoid arthritis, and they can worsen or initiate, apparently, demyelinating disease. When you see the ads for these drugs, they talk about the bad effects. They always then say, and neurological problems can happen. Well, the neurological problem associated with these drugs is demyelination. It's demyelinating disease. And it's very, very curious, and I've had a question about this for years, because when I showed you the slide on immune pathogenesis, TNF-alpha was one of the bad guys. TNF-alpha was one of the inflammatory cytokines that can damage myelin, damage neurons. And I've talked to colleagues for, I bet you, at least 15 years or more, I've been chatting with my immunological colleagues. Does anybody know why this happens? And no, nobody seems to know. And in the course of doing my literature research for this presentation, I came across something very interesting. And tumor necrosis factor alpha, there are subtypes. There's an R1 and an R2 subtype. And the R2 subtype can be impacted by the gut biome. And TNF alpha blockers reduce TNF alpha R2 type in the gut biome. And it's been shown that when that happens in experimental animals, that demyelination may occur in susceptible animals. So I finally, after searching for 15 years, saw there is a link there with the gut biome. There's a link there with tumor necrosis alpha, because HAT is a drug that blocks one of the bad guys in the pathogenesis of MS, cause demyelination in some unlucky individuals. And it has to do with an interaction with TNF alpha R2 in the gut. We may find out more about antibiotics. Antibiotics may play a role in treatment in the future, but we don't have any data right now. And probiotics too.
Anecdotally, as it relates to the gut microbiome, do you find that you maybe make the diagnosis of MS less in patients who are immunodeficient?
Well, that's a good question. It's really hard. It's hard to answer that, but the thought would be appropriate, because in the animal model, if you have an animal with a sterile gut, you can't give them the experimental model. So that may be so. I haven't seen flagrant MS in the HIV population, and remember, I've been practicing long enough so that I saw patients in the 80s before we had really good antiretroviral therapies, and I don't remember seeing that, but they get other CNS problems that could certainly look like MS, but we never thought that they were MS. One of my good friends and colleagues who directs the MS program at Penn, who used to be University of Kentucky, Joe Berger, looked at HIV populations extensively in the 80s when he was at the University of Miami, and he's one of the world's foremost authorities on PML infection, which he studied extensively in those days. And we're quite close friends, and we've had many chats about this, and I don't remember us ever saying that we saw a spike in MS in this population at all, so I don't think so. Unfortunately, there's a lot of other issues that will arise. And might it be protective against MS? That's a good thought. It might be, but unfortunately, all the other problems are certainly very, very significant, and probably not going to be a strategy that we choose, though we immune suppress a bit with these drugs, or we immune alter, we immune modify with these drugs. Sir?
What is your approach to someone who has an MS flare, and what would your recommendation be to us family physicians who get urgent calls from our patients with a suspected flare and can't get a hold of their specialist?
Yeah. So I get those calls too, so we have a lot in common. I'm still a busy clinician. I run a very busy MS practice at Rowan Medicine, so I get those calls as well. Okay. So thank you. So what happens is, when I get a call like that, the first thing I want to determine is this a real relapse or is it a pseudo-relapse? So pseudo-relapses occur most commonly when patients get infections or fevers. Patients with MS are very temperature sensitive. In hot weather, not 100%, but I'd say 75, 80% are very temperature sensitive. So if they get overheated, you and I, we all feel a little punky. If we're a little dehydrated and we're overheated, we're not functioning on all 12 cylinders, but we're getting around and we're not disabled. But someone who's had problems before with MS might not be able to walk again. I had a young gal years ago call me up, and this was in the early days of my career, and I just diagnosed her with MS. She was about 18. She had optic neuritis. She recovered. She calls me up, Dr. Barone, I can't see. And this is when I was an intern at Kennedy, or new attending at Kennedy. And so you get overhead paged. There's no beepers. There's no cell phones. Where are you? What are you doing? Well, she was a paralegal working in Philadelphia. Well, I'm on my lunch break. I'm at my exercise club. Where were you? I was just in the sauna. She clearly got overheated. Clearly, the old optic nerve problem made her blind again. And when she cooled down, she got better. So I'm always wondering, do they have an infection? The most common infection, UTI. And it's not always apparent, but I will ask the patients, You know, do you have a fever? Do you have chills? You know, if you're really declining, go to the ER and get checked. Or if it's during the day and you can get your primary care doctor, and I always try and engage the primary care doctors. It takes a village to take care of these patients. And so check the urine, check a white count, make sure they're not infected first, make sure there's not some contributing problem. If in fact there is not, then we do treat with corticosteroids, and I give 1,000 milligrams of Cyamedrol. It's pretty standard care, IV for 3 to 5 days, usually 3 days. If someone has had IV steroids in the past, I will do home infusions. If someone has not ever had IV steroids before, I won't do a home infusion the first time. I've had patients get psychotic and have other problems with IV steroids. It's not common, but it can happen. So that's basically what I do. The first question that occurs to me is this an exacerbation or not? In clinical trials, exacerbations have very strict criteria. Obviously, we can't mark down every little thing a patient calls about and say, oh, it must be a relapse. Let's check that off in the research box. So patients have to have a new definitive neurological deficit, and they have to have something on exam that we can corroborate with. But in practice, our definition's a bit more liberal. Well, I don't tend to use oral steroids, but it's a fair question, and there's not much data on it, but there's some data to suggest that the oral steroids might be as good. I don't tend to do that. There was one trial that dissuaded us, and I don't think it's a real strong data set, but the trial was called the optic neuritis treatment trial, and it was carried out in, well, the 80s and 90s. And one of the principal investigators was one of my colleagues at Wills Eye Hospital, Neuro-Ophthalmology Department, and a lot of people around the country contributed to it. I was a contributor to the study, but not a principal investigator. And in that study, if someone got optic neuritis, they were randomized to get oral steroids, nothing, or IV Cyamedrol. And for whatever reason, the patients that got oral steroids seemed to do a little worse. I don't think the data set is going to preclude perhaps the reemergence of oral steroids, but I think we've shied away from it for that reason. But I don't think there's any reason not to do it. The problem is that to get equivalent doses, when you're using a whole bunch of prednisone, the equivalent dose, is about 1,000 milligrams orally. So, because we use methylprednisolone, the difference between the two is minuscule in terms, I think, 5 milligrams of one's equivalent to 4 milligrams of Cyamedrol, methylprednisolone. So the doses would be about the same. I have a colleague at the University of Texas, Elliot Froman, a very well-known, nationally, internationally known MS neurologist, who uses like milkshakes or something to let him drink down dexamethasone in high dose. That's what he does. But most people give it IV, and I'm not, and that's just by convention. I wouldn't say that's totally a data-driven mode of practice. That just is the mode of practice. Oral would not be, an awful thing to do.